Okay, so I'm joined again today by Martin Pitman and Michele Worden. They'll probably be familiar to many of you by now. Michele was an advanced neonatal nurse practitioner at the Countess Hospital. Martin, experienced obstetrician and gynecologist, frequent guest on the channel. If you haven't seen the previous interviews, please take the time to go back and look at them, particularly the first part of this discussion, because last week we dealt with the first half of the recent BBC Radio 4 documentary on the Lucy Letby case and various alarming aspects of maternity care at the Countess Hospital. In our discussion today, we're going to deal with the second half of the documentary, which has some very meaty and important topics. So without further ado, I'll just say hello to Martin and Michele, and thank you for joining me.
Hi,
Hi,
Chris.
Chris. Hi, Michele.
Back. Hi, Martin.
Nice to have you here. So, Martin wanted to begin today with a little addendum to Freya. So, I believe that's the second parent that was discussed in the BBC documentary. So, there's something that Martin wanted to add to what was already discussed in our first video. So, we'll begin there.
Yeah, thanks, Chris.
Martin can explain that.
We had a sort of a detailed discussion about Freya's case, which was the tragic case of the what I believe to be a significant antepartum hemorrhage and then emergency cesarean section. And there were just a couple of thoughts of issues that I think are important about this case, which we didn't really touch on in the last episode of this. So I just wanted to go through those. It was certainly unclear to me, and I've listened back to the Phylum 4 documentary, and it's unclear to me about what actually caused poor little Oscar's death. Now, clearly, the actual delivery aspect of the cesarean section was difficult. There were 3 obstetricians involved. Now, the first thing to say about this is this will have rung frighteningly true to the first parent that we had contact with. So that was Claire and her partner, Carl. Now, they gave the story of an extremely protracted cesarean section that took them 47 minutes, apparently, from knife to skin to delivery of Jessica. So here we are with another story of an emergency cesarean section where there was an extreme level of difficulty requiring ascending levels of experience to get a baby delivered. Now, clearly that in itself, depending on what the actual indication was for the cesarean section, would put the baby at risk of hypoxic injury. But it's a little unclear, and it may well be that Freya didn't want to disclose the actual mode of poor Oscar's death. But I wonder if there may have been some sort of physical injury that was inflicted on Oscar during the delivery process. So that is unclear. So I just thought it was worth just highlighting that we've got another recurring trend here of management of an obstetric case, where either with, I think, Claire's case, there was a complete lack of appreciation of the likely difficulty, the predictable likely difficulty of a transverse lie back down cesarean section for that one. But then here we have another case where there's a significant delay. That was just what I wanted to add to what I said about that case last week.
Yeah, that's great. If you want to, if viewers want to hear the full picture and our full discussion on that, that's in a video that I recorded last week with Martin and Michele. So do check that out. Essentially, there were 3 parents that were dealt with in this BBC documentary, and in the first video, we drilled down into the issues related to the first 2 parents. So now we're going to move on to the third parent, who I believe was called Kat, and her circumstances were dealt with, I would say, a little bit more quickly than the other 2, but there were still some alarming issues in relation to her maternity care. So I'm going to ask Martin firstly to just give his view on this and make any observations about what we heard about Kat in the BBC documentary.
Yeah, sure, that's fine, Chris. Yeah, so Kat gives and I agree with you, it was a very brief description of her induction and delivery and self-discharge from the ward after the birth of her daughter, Eden, who was her first baby. And unfortunately, there are some errors in the description of this from the journalists that did this documentary. So I'll just go through those. Now, obviously, I have the benefit of being an obstetrician, so I can interpret and understand what Kat is describing. And to me, she gives just about the most perfect description you will ever hear from a patient of what is termed prostaglandin hyperstimulation. So Kat was admitted to the Countess of Chester for an induction of labour. I'm assuming it was because she got to the end stages of the pregnancy and may even have got beyond her due date. So what midwives and obstetricians do in that situation is to recommend induction of labour. And there are various methods by which that can be expedited. And most of them deploy the pharmacological use of a chemical called prostaglandin, which is one of the chemicals that is implicated in the natural onset of labour. Now, in this situation, there are various choices and different modalities of administration of that. It can be given in a tablet form, a pessary form, a gel form. But Kat was given, it sounds, she described a pessary. So I'm assuming that was a compound called Propess, which is a compound that's had a pretty checkered history in obstetric practice. It was introduced back in the 90s and then withdrawn due to a series of pretty horrific complications to both babies and mothers, including some deaths. And then it was reintroduced probably about 10 years ago under a different name, manufactured by a different company. And the problem with it is it's a very, very high dose of prostaglandin compared with the other formulations. So it's designed to be inserted into the top of the vagina, and it works over time to soften the neck of the womb. It sensitizes the womb to circulating oxytocin, which is the natural maternal hormone that causes contraction. And over time, those two processes allow the cervix to get to the point where you can break the waters. They use a little what's called amni hook to break the waters. It became incredibly popular about a decade ago because of its basically kind of fit and forget nature. So unlike the other prostaglandin preparations, which were a shorter period of action, this was designed to be used for a 24-hour period. So it became attractive when problems with midwifery staffing levels became an issue. And I think that's exactly what is demonstrated here with Kat's care, because it gave the midwives the ability to insert the pessary. And then you can, exactly what I said with the other two cases, you can normalize things. So by normalizing what is going on, and Kat gives a very good description of basically saying she was extremely uncomfortable, she was in continuous pain, she felt terrible. Now, all of that to me is describing somebody who is getting what's called supraphysiological contractions. So rather than getting infrequent and then regular contractions, she was getting almost a continuous level of contractions, which is incredibly uncomfortable. And some patients, single figure percentage, but not insignificant, are exquisitely sensitive to prostaglandin, so they can get this systemic discomfort and horrible feelings associated with prostaglandins. And it appears she was describing this to the midwives, but they were saying, no, you're not in labour, no, you've got a long time to go now.
So can I just
whereas in reality,
can I just ask a question, Martin?
Yeah.
So as you're about to say, they were very dismissive, basically. Is this something that you'd usually be medicated against, or would you receive painkillers?
The only treatment for it is if you recognise it, and it's not a difficult thing to recognise and B to diagnose, and that's another critical omission here, in that the midwives were dismissive of her symptoms. Now the reason for that is about labour intensity, and I mean labour as far as the midwives are concerned, because if you're saying to somebody that they're not in labour, you don't need to provide one-to-one care, you don't need to monitor the baby's heart rate with a CTG. And that's what I think was going on here, because Freya was given no support, no analgesia, shockingly had no fetal heart rate monitoring from the time of the commencement of the induction, according to her, until she was proven to be fully dilated, which breaks every single fetal monitoring guideline that's ever been written, particularly when you think of the number of contractions that she must have had, bearing in mind it was her first pregnancy. So they had no idea of the fetal status. At one point, they even encouraged her to have a bath, which again, in my experience, is a midwifery way of saying, well, you put yourself in the bath for an hour and then that's another hour, we don't need to do anything. So all of that is shockingly deficient care. She then gives a story of of wetting herself. Well, she probably was. And the reason for that is it then becomes clear later on that she hadn't emptied her bladder in the entirety of the labour. Now, again, that's a massive deficiency in midwifery practice, because when somebody's labouring, it's part of the midwifery's role to check whether the lady's emptied her bladder. The reason for that being that because of the discomfort down there with the contractions, it can sometimes not be obvious that they need to go. And the other reasons are that if you've got a bladder that's full of urine, it actually adversely affects the progress of the labour and the dilation of the cervix, but it appears that was missed. So the error in the way this was described is it was described as a spontaneous labour. This was very, very far from a spontaneous labour. This was a medically induced and I think mismanaged induction of labour, where poor Cat was exposed to far too much uterine activity from non-recognition of hyperstimulation. They said that inductions using this agent normally takes between several days, I think they said. I can't remember the exact wording. Well, that's pretty unusual. Normally you get somebody into labour within 24 hours of one application of the Prof. So we didn't really hear much about the actual delivery, but I'm assuming the actual delivery of Eden was relatively straightforward. And then, of course, what happens after that is entirely predictable, because the uterus has been battered by this agent. And then once the baby's out, the uterus doesn't contract because it's completely knackered. It's a bit like if you've been over-exercising, doing a marathon, your muscles don't work well. So utterly predictably, in her case, she then went on to have what sounded like a massive postpartum hemorrhage, exacerbated by the fact that her bladder hadn't been emptied. And if the bladder is full, the uterus won't contract down, which makes your bleeding worse. So I suspect the extent of her bladder mismanagement was only realised when she had the massive postpartum hemorrhage and probably had a catheter put in. And I suspect there was an enormous volume of urine that was removed from the bladder. And then, of course, bless her, she was so fed up with how little input she'd had that she then self-discharged. And then only kind of realised in a way, she went on to develop post-traumatic distress, which was hardly surprising, and then only realised in her subsequent pregnancy, when she went to another unit, of what attendant midwifery care should represent. So clearly Eden was born in good condition, has got no attendant problems, but I suspect that was probably more by luck than judgment. She'd passed meconium, which is commonly an indicator of a baby being at best a bit unhappy with what was going on, and at worst, if they become hypoxic, which with hyperstimulation is more likely, they can actually snort that down into their lungs, which can be a real problem. So a good outcome, but a lucky good outcome, I think.
Yes. And I want to ask Michele, this was referenced just very briefly by Martin, but this mother discharged herself, self-discharged from the hospital. That really stood out to me, the detail, because obviously if you're going through a traumatic experience associated with something that is a fairly acute medical situation anyway, discharging yourself from the hospital is not a good sign, is it? So I just wondered what you thought about that, and if you have any kind of comments and anything to add to what Martin said.
Well, I totally agree with Martin. If we just for a minute go back to the baby, I think they were extremely lucky to get away with a baby that didn't require neonatal care, because meconium aspiration, which is when babies inhale the meconium from the liquor, can be a really serious illness and make those babies incredibly sick, requiring intensive care. So I think they were extremely lucky that baby Eden was fine. The mum discharging herself, I can't say I'm surprised at. Again, she feels dismissed. She's not being listened to. Her concerns have not been listened to, and you just want to run away. You want to get out of there. Probably even upstairs on the postnatal ward, again, not enough staff. If we go back to Annie's case, Annie talks about actually walking down the stairs within a few hours of having a general anaesthetic and a cesarean section to go and see her baby because there's nobody around to take her. That is potentially very dangerous for that mum, but is again just indicative that not enough staff, no care, very little compassion. So I can't blame Kat for wanting to discharge herself and just take herself home.
Yeah, absolutely. So in the programme, after we'd heard from Kat, we then went on to, I think, a critical section that we're going to discuss in some depth. And that began with, I've forgotten his first name, Professor Bennett. What was his first name, Martin?
Professor Phil Bennett.
That's it, Phil. So Professor Phil Bennett appeared, and he is now affiliated with the panel of 33 experts that are examining the conditions around the Countess of Chester Hospital and effectively acting in the defence of Lucy Letby, although they're not actually defence experts. They're just experts that have looked at things dispassionately, essentially. And Professor Phil Bennett had a lot of interesting things to say about child O in particular. Now, just to contextualise this before we go any further, this is a critical case in the conviction of Lucy Letby because it was one of 3 unanimous cases. At the time, it's deeply ironic, but child O and child E, I think, were seen as strong cases. Now, those cases are not seen as strong. Child E is just a very obvious gastrointestinal hemorrhage, and we're going to discuss child O today. Professor Bennett had a lot of things to say about this infant and about the lack of obstetric input and various important things. Now, some of these things Martin has already discussed at length on this channel in my previous interviews with him. But we'll begin by just talking about Professor Bennett and what he had to say. So what are your views on that, Martin, firstly?
My first view on listening to Phil Bennett, who I know of old, was one of relief, really, because this aspect of what I see as a travesty, really, in the way these cases have been misinvestigated. And I went out on record, I think it's probably in the second interview that we did, saying that it was, in my view, a huge deficiency that so little attention had been paid to the maternity and obstetric histories of these cases. It was perfectly obvious from the paperwork that was readily available and was shown to the court and was available in documentation afterwards that there was a negligible amount of detail about the critical obstetric histories of these cases. And to hear somebody of Phil Bennett's calibre and status as one of the most senior and respected obstetricians in the UK, basically agreeing with my opinion was incredibly reassuring. There are 2 parts of this, of course. There's the generic part of it, which I think is of critical importance, that I don't think any right-minded clinician, be they obstetrician, fetal medicine, neonatologist, neonatal nursing, or any other non-related specialists would say that it is in any way appropriate to ignore the maternity and antenatal history when you're assessing what happened to a baby postnatally, particularly neonatally. It is of fundamental and critical importance, which is the point that he was making. And just to broaden that a bit, I think Phil was touching on this, but I think time ran out for them to say it. If you look at what systems have been brought in place over the last decade when maternity standards have been dropping. So if a unit gets a bad outcome, then we've had several different ways of investigating this. So in sort of chronological order, we've had HSIB, we've then had HSSIB, and that's been swallowed up by the CRC, and then we've had PMRT reviews and more recently MNSI reviews. Each of those are sort of internal ways of a unit to investigate serious maternity outcomes, of which all of the indictment cases would have been included. Now, every single one of those, without exception, requires an integrated investigation process. So by that I mean it is imperative to have obstetric input, neonatal input, and midwifery input. Okay, so trusts have known for a decade that you need to look at all the maternity records, all of the delivery records, all of the fetal medicine records, if there are any, all of the neonatal and resuscitation aspects before you can make a decision on what happened to a given case. So now we are being led to believe that it is appropriate in the legal system in this country that you can completely pretty much ignore one component of that, a critical component in mine, clearly Phil Bennett's view, the maternity and obstetric part of that, when you're deciding whether somebody's guilty of malfeasant murder of babies. You can forget all of that, which is just astonishing. And I think that's of particular relevance to Baby O, which then Phil went on to discuss. And you know, the crazy thing about Baby O from this perspective is it would take 5 minutes of looking at Baby O's maternity and particularly delivery record, and the one piece of paper that would absolutely solve this would be to look at the record of whoever the obstetrician was who was holding the scalpel at the time of the cesarean section. And it is just incredible that that court case happened and that Lucy Letby was found guilty of murdering Baby O without anybody looking at that and without that surgeon being questioned under oath. I just find completely staggering. Clearly, there was concern at the Countess of Chester about that delivery, because we didn't find out during the trial, because presumably that wasn't disclosed, but we found out in Thirlwell that concern had been raised internally at the Countess of Chester about the conduct of that caesarean delivery, and somebody had been given responsibility to investigate it. Well, who was that? What format did that investigation take? Where's the documentation from it, and what was the conclusion? Oh, nobody seems to know. Well, why don't they know? So yeah, staggering, and you know, of course, armed with that knowledge, then it isn't really difficult to do what Phil Bennett has done, which is to look at in his own words, the impressive array of literature that there is on this specific topic, and it's enlightening if you do. And how condemning was it that his conclusion was that the experts that fed into the discussion of this case in the actual trial, he feels cannot have looked at the evidence about subcapsular hematomas and how they occur. Because if you do, it's all there, and the natural history of them fits perfectly, absolutely perfectly, with what happened to Baby O. So knowing what we know now, that there was concern at the time about the delivery, all we've got to go on that is the mother's recollection of it. So she gave a very, very graphic description, because it would have been fairly frightening of the cesarean section starting and there being a big sort of whoosh of blood that came from the operative field right over the drape, splattered her and splashed against the wall in the operating theatre. Well, that's completely unprecedented. I never had that in 30 years of doing cesarean sections. So what was all that about? And it is quite possible. Phil Bennett's theory was that the surgeon went through a big blood vessel, it caused that bleeding, and then there was a rush to get the babies out. So if that was the case, and if it was the case where Baby O and Baby P were breaches, and they were delivered by what's called a manipulative breech extraction, which requires rotational forces, then there you have it. There you have your rotational shearing force, which can be implicated with the trauma required to cause separation of Glisson's capsule over the liver and to cause a subcapsular hematoma. And it doesn't actually matter to a certain extent the condition that the babies were delivered in, because the natural history of the condition is you get the hematoma that forms, it gradually gets bigger, and that's difficult to diagnose clinically. And then what tends to present is you have a baby that's a bit grizzly, doesn't handle very well, has concerns with respiratory issues and possibly observations that deteriorate exactly as baby O did in the 24 hours prior to the collapse, which were trivialized and not managed appropriately. And abdominal distension, which baby O had and was examined. Now, loads of stuff floating around is in the people are saying, oh, the baby O was examined and there was no evidence of a liver injury. Well, you wouldn't find it on basic examination. The papers tell you this. The only way of finding it is if you do imaging. So either an ultrasound scan and cross-sectional imaging, which of course never happened, even in the pre-terminal stages where a needle aspiration was performed and was put in astonishingly without ultrasound guidance. Now, the very consultant that did that...
Martin, I've asked Michele about this previously. We've spoken about this. Why didn't you use ultrasound guidance? Do you have any notion of why?
It's astonishing to me that the same consultant that did that attempted needle aspiration had earlier done an echocardiogram, which is exemplary care, because you've got an unstable baby, and one of the things you need to rule that out is to check that the baby hasn't got a congenital heart problem. Brilliant. So he's clearly a skilled sonographer, because to do that requires a lot of skill. All he needs to do is to take that ultrasound probe and put it 2 inches lower, and it should have been absolutely blindingly obvious that you've got a big collection of blood either around the liver or more likely, in addition to that, in the peritoneal cavity, because that amount of blood is going to be obvious. I have no idea. I would have expected, if you're going to do a peritoneal aspiration, which is what this was, even if you're going to do it on the safer of the two sides, which is on the baby's left-hand side, you would still do it under ultrasound guidance. But if you're going to put it on the right-hand side, which is basically a no-go zone in neonates, because the liver is always a little bit below the lower limit of the ribs, made worse in this case, as Michele, I'm sure, will go on to describe, by the fact that the inflation pressures that were used with this baby were unusually, if not inexplicably, high. So the liver was pushed down by hyperinflated. I cannot even fathom why you wouldn't use it. The ultrasound machine was clearly there, so I've got no idea.
Yeah.
Michele.
So I just want to ask Michele about this, but I just want to add a couple of things while I remember. So the first thing is, categorically, the court did not hear about this. So the court did not hear about the blood splattering that Martin just described as unprecedented. Categorically, Dewi Evans did not mention this in court. Categorically, Bohin did not mention this in court. The second thing is, we can't say this with 100% certainty, but I would say it's overwhelmingly likely that Evans gave his opinion in court without even knowing that it had happened, because this was picked up by Professor Phil Bennett from statements made by the parents. So given that Evans did nothing apart from look at the neonatal notes, he probably didn't even know this happened until the other day. In fact, he may even now not know that it's happened because he hasn't seen the report. He said that himself, and he very obviously and very evidently, as we're going to discuss later, made no effort to see the obstetric or maternity notes. We don't even know if it's in the obstetric or maternity notes, but we definitely know he didn't see them anyway. So it's very likely that he stood up in court and gave his view without even knowing this had happened. So I just want to make that clear. So
the other thing, just to interject, Chris, is you could actually very easily argue that how the subcapsular hematoma was formed is irrelevant. We're being led to believe that we have to accept that Letby, it was an inflicted injury by Letby, a punch or something. But if we're going to hypothesize that actually is very, very far away from what actually happened, then I don't see it as a weakness of the defense case to say, well, which is very, very common in medicine. You can say, well, these are the possibilities. So I've always said, until I heard about the existing concern about the nature of the cesarean delivery, I went on record as saying, when we discussed it before, I said I thought it was far more likely that it was a combination of several factors. So premature, all of which again, if you look at the research, predisposed babies to getting these hematomas. And I thought there were three in this case: prematurity, a monochorionic triplet pregnancy where you've got diversion of blood supply between the babies, and exposure to hypoxia. Now, all three of those are linked with it. So I don't see it as a weakness of the defence case to say, well, these are the options, but the most likely one, which I now happen to agree with, having seen the existing concern about the delivery, almost certainly is a traumatic delivery. But it's incredibly easy to prove that.
Yeah, I mean, we'll get on to discussing the prosecution case in a bit, but I want to ask Michele about child O. So we've actually discussed this in some detail previously. We've discussed the laceration of the liver. I'll get into that in a bit. But what did you make of the whole section related to child O, and do you have any comments about it generally?
Yeah, I've witnessed numerous cesarean sections, and I've never seen anything like that Mum describes at all. So Martin is an obstetrician. He's actually performed the cesarean section. So I think his knowledge quite clearly says, that this was a very traumatic delivery. As Martin says, I've always thought the subcapital hematomas were possibly due to, it was a multiple birth, they were identical, and they were premature. And the literature all says those can be causes plus a traumatic delivery. So we are never going to know really what caused that hematoma. We know his brother, baby P, had one as well. But I think that's irrelevant. The fact is that when this baby was on the neonatal unit, to me, they missed very subtle signs that this baby was slowly deteriorating. It was reported overnight. He had a distended abdomen. He had visible loops of bowel. He was tachycardic. He was tachypneic. He was reviewed a couple of times by doctors who said, keep feeding him, he's fine, his tummy's soft. But those are very subtle signs of babies saying, I really don't feel very well, until the point comes, which I think was 1:30 lunchtime, when he had a profound desaturation and bradycardia, which they claimed was unexpected. To me, it was not unexpected. This baby had been slowly deteriorating for 12 hours because the first recorded observations going slightly awry is at 1:30 in the morning. This is 1:30 lunchtime now. So a crash call was put out. He was ventilated, moved to intensive care, started on ventilation pressures, which I think for a baby that clearly didn't have respiratory distress syndrome were too high. But my big criticism is this baby had one peripheral cannula and the registrar left. He didn't put any further lines in. Now, by definition, if you've got a baby who's already had profound bradycardia and desaturation to the point where you've ventilated them, he should have immediately started to think, I need to put an arterial line in, I need a long line, at the very least, another peripheral cannula. But he did nothing and left. And then when this baby had yet another really major desaturation, profound bradycardia at approximately 3:30, quarter to 4, there was mass panic then. They couldn't get any lines in because this baby was peripherally shut down. Eventually, they called Dr. Gibbs to come and put an intraosseous infusion in. But the failing was at 1:30. I mean, that registrar to leave a baby in intensive care with one cannula is huge. And then the failings just continued. As Martin has clearly said, Steve Brearey was called. So now you've got 3 consultant paediatricians at this resuscitation. He echoed the heart. The baby didn't have congenital heart disease. Why on earth he didn't echo, ultrasound the abdomen, only he can answer that. But the really significant thing is that he documented in the notes, one of the experts who's written a report told me it was Steve Brearey who wrote it in the notes that this hemoglobin was only 86. Now, whether he knew the hemoglobin at 1:30 was 197 really is immaterial. He should have recognised for a 2-kilo baby that a HB of 86 is half the circulating volume. And not one of these 3 consultants thought to themselves to give this baby a blood transfusion. And the registrar. So there was 3 consultant paediatricians and a registrar, and not one of them thought, just as in desperation, let's give this baby some blood. They didn't do that. So I think there's numerous failings during this resuscitation, which we've seen in all the other resuscitations as well. This is, again, a reoccurring theme.
Yeah, so it's not the only case in which a blood transfusion was delayed or not given, is it? Child E is the other one. So that's very interesting.
The difference, Chris, though, with this case is that what Michelle's just detailed, so that pretty profound and spectacular drop in hemoglobin, undoubtedly it would have been exaggerated a bit by the amount of non-blood fluids that they gave that baby. That doesn't explain it in any way. The critical thing is that what then became colloquially called sheet 97 or page 97 wasn't disclosed. So it never got into the court documentation and was never seen by the defence. So why was that? Well, why was that? And where was that sheet kept? And why was it not disclosed?
Yeah. So I'll just mention that I've actually recorded a video about Child O that I haven't put out yet. It will go out after this interview, and I've discussed that page. What's it called? Page 97, sheet 97, because you gave it to me. So I don't know if I was aware of that, but there's so much in this case and so many different things. You learn something new every day, don't you? So
the literature that Phil Bennett speaks about, if you look at that, then the outcome if you have a rupture of a subcapsular hematoma is notoriously poor. But all of the literature says if you're going to stand any chance, then you need to resuscitate the baby effectively and you need to replace the blood. Now, the fact that 3 consultants and a registrar decided to abandon the resuscitation of a neonate in this clinical situation without giving blood, I find staggering. And we also need to bear in mind that I think pretty much you'll probably have a better idea than me, Chris, but I think uniquely the needle aspiration procedure in this case was about the only criticism that Dr. Sandy Bowen raised about any of these cases. Even she suggested that it.
Let's be clear. Well? She did at least mention it.
Yeah. She said it needed to be looked at in more detail, I think was the way it was worded.
So you do know this was mentioned in court. That's not commonly known, I think. But it just shows you the kind of witless commentary and witless comments that we see on social media. Some people try to pretend that the needle aspiration doesn't exist, even though it's in the third ward documents. But more importantly, it was acknowledged in court. It was fully acknowledged. It was fully acknowledged that he'd drawn blood. Dr. Brearey was named in court by Dr. Bowen, and yet some people say, "Oh yeah, that never happened," and Dr. Brearey's going to sue people. Well, I don't think he will because it was in the court case.
Why didn't Dr. Brearey, when he inserted the cannula and withdrew blood, that in itself should have raised alarm bells with him? Because he inserted the cannula to remove air because the abdomen was so distended, but instead he removed blood. That again was a complete failure to think, oh, what's going on here? And again, as Martin said, he had an ultrasound scanner with him. He could at that point have just run the probe over the abdomen and seen a massive peritoneal bleed. But he didn't do that.
And of course, the details of that invasive procedure were not included in the pathologist notification, and they were not included in the details that were fed up to the coroner. Well, why weren't they? Because that was critical, nor were the contents of page 97. So why? The coroner didn't find out, was it for 3 or 4 months after the death? Well, why?
Yes.
It was Stephanie who highlighted it when she
Yes.
started to hear concerns about this trial.
Yeah. So obviously I hear about all this stuff, and I've spoken to Shu Lee about this, and he told me basically they did everything fundamentally wrong. The treatment was it's not just that it was bad treatment, but they just didn't do the right procedures even, and misdiagnosed, and they made medical errors, and all of these things compounded one another.
And they
So,
said that a lot of things which I think just sound very impressive to a layperson, but are actually totally irrelevant in neonatology. That was Steve Brearey saying he'd inserted it at McBurney's point. Well, that's to diagnose an appendicitis. I've never seen a neonate with an appendicitis. It sounds very impressive, but actually it means nothing.
Yes. So what I wanted to ask both of you really, I'll ask Martin first, then you can add Michele. How fundamental and how basic are these errors? Not diagnosing it in the first place, doing the wrong procedure, making a medical error with that procedure, ventilation pressures were wrong. It seems like they got everything wrong with this case, and I accept that it's a difficult situation in that a subcapsular hematoma is not an easy thing to save the infant from, as it were. But I was told that with correct treatment, it's an avoidable death again. So how poor would you say the treatment was here, Martin, firstly?
I think we need to bear in mind, Chris, that if you put yourself in the place of a non-medical juror, which is what we need to do with this would have been incredibly complex and traumatic stuff to hear about. The other thing about this specific neonatal diagnosis is it's incredibly rare. I mean, I went on record saying that I'd never seen one, I'd never knowingly caused one, I'd never even heard about one in my 30 years of practice. I was then reassured to hear that Jim Thornton, who's got a good sort of 10 years on me, the same, as an even more experienced practicing obstetrician, hadn't, and it's clear that Phil Bennett hasn't either. So now that doesn't mean actually that the incidence of them is that low, but what it does mean is the incidence of life-threatening ones must be very, very low. So we've probably had them in cases we've been involved with, but they've been subclinical, they self-limited, and they self-healed and corrected and were never then diagnosed. Now, the critical thing as far as the jury were concerned, and Phil Bennett very, very carefully said this when he was interviewed, is the only way that the jury could have been expected to have really understood the pathogenesis of how these things happen would have been to have had an obstetric expert giving evidence at the trial. Because to convince the jury about how this is most likely to have happened, and basically it's going to boil down to, was this a traumatic episode? Was it one of the other things the other predisposing factors that both Michele and I discussed, or was it that Lucy Letby deliberately harmed the babies? For the jury to make up their minds, then you need somebody experienced obstetrically to present that, and then under cross-examination, which would clearly have happened, you would have needed Johnson to have interviewed Phil Bennett, say, and then Phil would have quoted all of the papers that would have backed up that opinion, and then it's a done deal, isn't it? Because I don't think any jury would have said, "Oh, no, I don't think that's right. I'm sure Lucy Letby just gave the baby a right hook and caused this." As far as I think of any kind of medical procedure, and I think and resuscitation is a prime example of that. Pretty much everything in medicine now is protocol delivered, and if you're going to be an effective senior individual who's effective at resuscitating neonatal babies, what you do has got to be absolutely reflex. So this is what you're faced with, this is what you do. So and the first error that Michele very eloquently described there was the lack of foresight, and how many times have we heard that throughout the Letby indictment cases? The registrar clearly didn't think what might have happened with this baby, so didn't put enough lines in. Now, the reason that's important is that if the baby does then deteriorate, which it may not have done, but it did, then it's far harder to get lines in once a baby's shocked and hemodynamically unstable than it is if the baby's just a little bit wobbly. And then everything from there on, it just shows that that innate reflex ability to manage with a clinical scenario. It's the same as an obstetrician doing the cesarean. Okay, they hit a big blood vessel, but that can happen. But you need to then safely get yourself out of the problem that you've caused. And it doesn't seem to me that in any of these cases that the resuscitation was appropriately and effectively managed, because none of what we've just described, the deficiencies, are rocket science. You need access. You need to think, well, okay, we had a hemoglobin that was 196 4 hours ago, and now it's 86. Well, we've given some fluid, but this baby's bled. You stick a needle in, you draw out blood. This baby's bleeding into its peritoneal cavity. Both of those indicate urgent blood transfusion, not abandon the resuscitation. So none of that is rocket science or should be challenging. But so I don't think any of this is, from that perspective, difficult. I think getting your head around a subcapsular hematoma, which is a rare complication for the most experienced obstetricians to see, would have been impossible for a juror to have got their head around. But they weren't given the chance because there wasn't an obstetrician giving them the benefit of their experience and what the relevant literature presents.
Thank you. So, Michele, what do we think about the prosecution case for Child O at this point in time that is reliant on Lucy Letby supposedly striking this infant in the liver?
Well, if we just take the practicalities of that, this baby is in an incubator. Incubators are quite tight spaces, and this is quite a big baby. He's 2 kilos. For her to whack it in the liver is, I just can't imagine how anybody could do that through either the portholes of an incubator, which are very restrictive. To get the force to punch a baby would be quite hard. Did she use an instrument, supposedly? Who knows? Even if you took the cot side down, the incubator side completely down, to whack a baby in the liver, I still think you're in you've got a ceiling, you've got a bottom, you've got sides. It's a confined space. You haven't got the space to suddenly just throw your arms at this baby. I think it's just ridiculous. It's one of Dewi's hypotheses, which in reality are not feasible by any stretch of the imagination. But you've got the prosecution who had so-called experts using language which is very emotive. This injury was equal to a car crash. That's a very visual, impactful statement. And I can understand why the jury would go, wow, that's, cars are usually traveling at 30, 40 miles an hour. Is that the force that was used? Because that's the implication. So the prosecution told a very good story, but I don't believe it's factually accurate, and I don't believe it's actually feasible when you actually get down to the practicalities of handling a baby within an incubator. And nobody saw her do this, of course. Secondly, Dewi constantly changed his story. He said that it happened at night, then it said he happened at 7 a.m. Well, Lucy didn't come on duty till 7:30. And then he said she must have done it at 9 o'clock. But we know from the records, this baby was slowly deteriorating from 1:30 in the morning. And that is recorded, that the abdomen was becoming bigger. There was visible loops of bowel. As I said before, the heart rate was going up. The baby was breathing a little bit quicker. All of those signs were there, but nobody really picked up on this baby's slow deterioration.
Yeah. So I personally believe, this is just my personal view, you can read in my book, Dr. Shuley says, why did Evans effectively go looking for methods of malfeasance instead of looking for more natural explanations for these phenomena? And I think this is a classic example of that, where under no normal circumstances would you, if there was a subcapsular hematoma, would you think, well, which one of the nurses has punched him in the stomach then? There's no conceivable way you would say that. And I was told specifically this kind of, it's described in the panel documents as blunt force trauma, just cannot create the observable conditions in this infant. So based on what we know now and based on that, I just consider the prosecution case to be completely untenable. And I think it's embarrassing that this went in a court.
But if
And
you just say hypothetically somebody had whacked this baby in the liver, there would be a massive bruise on the skin. There is no documentation that this baby had a bruise, a visible bruise on the abdomen. It was all internal, and that's why during the resuscitation they didn't join up the dots, even though they had signs. Steve Brearey's drawing back blood, the hemoglobin's dropping, but they didn't consider that that's because that baby's bleeding. But there was no visible outward signs. If you have a liver injury, as described in court, that's equivalent to a car crash, surely you would have a bruise of some description on the skin.
well, you would think so.
Martin Reed has covered that off, though, didn't he, by saying you can at times, and I have to say because there was another case that somebody dug out of his where he'd used it was another paediatric postmortem that he'd done where he'd used exactly the same description in another court case of it appearing like a car crash. So clearly this guy knows how to influence jurors' opinion by using really emotive terms, but he covered off that aspect of it, I think, in the trial by saying that it wasn't unusual to have limited out external signs of bruising with massive internal signs of liver damage. But I completely agree with you, Michele. If it has to be far more likely that if a nurse had deliberately whacked a baby from the outside, you're far more likely to see an external sign of that rather than it being a shearing force at a cesarean section that tears, glistens capsule, and you get an initially a self-contained bleed that then ruptures. And I can see in that situation, which is by far more likely, that you're massively less likely to see any external signs of bruising or bleeding.
I mean, ultimately, Martin, there is no basis to make this assertion, is there? It's just something that he made up. It's because there had to be a Lucy Letby explanation for this infant. He couldn't explain the subcapsular hematoma. He didn't try to look at the obstetric notes. He didn't try to look at the maternity notes. And it's just something that he came up with off the top of his head.
But he even went further because he covered his options by saying that she'd also injected baby A with air and put excess air and milk down the NG tube. So he was really, this was a triple whammy, wasn't it?
Yeah.
So, he was.
He knew all of this within 10 minutes, because let's not forget, this was the first baby that he was given the notes to.
Yeah.
And you and I know, Martin, how long it has taken the experts to trawl through these notes, observation charts, intensive care charts, blood results, but he knew within 10 minutes.
Yeah. So I think we've dealt with child O and the obstetric situation pretty thoroughly. So the next bit in this BBC documentary was Cleuci d'Oliveira, who'll be known to many people as the owner of the Trials of Lucy Letby X.com account. She appeared to discuss a maternity review, I believe it was, that took place, and some monitoring issues. So could you comment on that, Michele, and just give me your view on that section of the documentary?
Well, it wasn't completely clear, but she talks about the heart rate, which I think must relate to the CTG monitoring of a baby's heart rate. As a midwife, every year, as part of our maintaining our license, when I was there, we had to fill in a computer program that showed you numerous different CTG patterns and recognize what was going on with that particular baby, and you had to pass it. I don't know if that's still true, that midwives still do those computer programs, but there was obviously an issue because this report highlighted that they were misinterpreting the heart rate patterns on what we presume must be the CTGs. And it goes back to training. It goes back to possibly not enough monitoring or the wrong monitoring. We know from Kat's pregnancy, baby labour, she wasn't monitored at all. And that baby must have had some degree of fetal distress because when she was born, there was meconium. So, yes, it raises big concerns about the maternity care that was going on and who was looking at and looking after these mothers and babies.
Can we just explain the significance of meconium and what meconium is, please?
So meconium is the effective first feces that lines the baby's gut. It's very thick, black, tarry substance. And occasionally, when a baby is in distress in the uterus, the baby defecates and it goes into the water that surround the baby. The danger with that is that babies in the uterus can gasp, and they will gasp and inhale it. And because it's thick tar, it goes into the lungs and can cause really bad problems. Terrible infections, the lungs won't open properly, and babies do die of meconium aspiration. It's not to be trivialized at all. It's a very serious condition.
And there were several infants in this case where they were struggling to pass meconium or they didn't pass it.
That's different. That's post-delivery.
Mm.
There are various conditions where a baby will have delayed bowel openings. They might have Hirschsprung's disease or, be extremely premature. They're not being fed. I mean, one of the things that makes you defecate when you're first born is that you start feeding. So food goes in the top and feces comes out the bottom. If a baby's very sick and they haven't had food to digest, then there is a delay in defecating. But that's completely different than what happens in meconium aspiration, which, Martin, I'm sure, seen babies in distress, and he's delivered babies with meconium liquor, and it's not good.
Yeah, and that aspect of it, because the obstetric responsibility with that is if you're aware in a labour that there is thick or fresh meconium present, then what you need to do is to do everything in your power to reduce the chances of the baby developing hypoxia. Because what babies do in utero before they're delivered is exactly the same as if I was to push your head underwater. So the shock of it would cause you to gasp. And of course, if that happens to you underwater, it's a bit of a problem. But if it happens to a baby in utero and there's thick meconium present, it's an even bigger issue. So if they become hypoxic, then they gasp because it's a sort of an innate protective mechanism in the hope that you're going to be breathing in nice fresh air. And of course, they don't breathe that in; they breathe in meconium. So, yes, I mean, just going back to this maternity review, of course, we don't know a lot about it because I'm not aware. Cleuci D'Oliveira has obviously seen it, but I'm not aware that this was shown or discussed or brought up in the trial. I'm not even aware that it was part of the Thurwell documentation. It may have been, but I haven't seen it. So it was conducted in 2015. It was undertaken by one of the consultant obstetricians, and it was done because they experienced 18 stillbirths. And what Cleuci declared in the File on 4 program was that one of the main findings of it were concerns about monitoring. Now, I agree with Shell that the most likely interpretation of that is that there were deficiencies in the fetal heart rate monitoring of the babies. Now, it appeared that changes were introduced back in 2015 as a result of this regarding fetal monitoring, which should reassure future patients and parents going through the unit that things had improved. But then you need to think about, well, okay, that was in 2015. And from Kat's case in 2020, she had no monitoring at all during her labour. So clearly they didn't learn that much. And the other thing is, the look at every single maternity scandal crisis over the last 10 years, and a significant component of that in every single unit was deficiency in the way that babies' heart rates were monitored, be that the midwifery modality of listening in with a Doppler, or the higher tech way that obstetricians favour, which is using electronic fetal monitoring, and knowing when one needs to become the other. So again, it's yet another example of a deficiency being picked up at the Countess of Chester, which is absolutely indicative and consistent with what was going on in every other maternity unit where there were declared, diagnosed and accepted systemic problems.
And you have to remember, in 2020, they had an appalling CQC report on the maternity side.
Mm.
Yeah.
Not that surprising, is it? from what we've seen. Okay, so I think we've dealt with that. So in the BBC programme, they put all this stuff together. They put the child out stuff. They had Professor Bennett on. They had the mother that we've mentioned today. They had the previous two mothers that we discussed in the first part. All these very damning maternity issues, and then they finally came to Dr. Evans, who dutifully agreed to appear, as he often does. And they put these questions to him about, did you look at the maternity notes? Did you look at the obstetric notes, etc., etc. So I'm going to ask you both about Dr. Evans and what he said during the programme, but all I would like to say first is my observation was he sounded a lot less bullish than he has in the past. Obviously, he still maintained the position that he was right about everything, but he sounded quite diminished compared to what he has been over the last 2 to 3 years. So with that being said, Martin first, what did you make of the comments of Dr. Evans in this documentary?
I've listened to them several times, and each time I hear different things, really. But I completely agree with you that it's a very, very different tone from the one that we've become accustomed to. The first thing he said is he'd be keen to read Phil Bennett's report. Well, in the past, he's been very disinterested in anybody else's report, only believing that, that in his stunning level of arrogance that he's right and everybody else in the world, even if they're far more experienced and researched and evidence than he is, are wrong. So that was quite noticeable. So gone was the arrogance.
Unqualified, we should say.
Yeah, gone was the dogma. Gone was the absolute certainty of what had happened, and then it goes from that to quite spectacular, I think, inaccuracies in what he said. Because, and I made a note of his exact words. He said it was not unreasonable to suggest that there should have been an obstetric opinion involved in the assessment of the cases in the trial. Well, he's got a pretty short memory, hasn't he? Because there is documented evidence out there that shows that the National Crime Agency specifically recommended to the Cheshire Police that a multidisciplinary panel, including a consultant obstetrician, should be assembled to do the initial assessment of the cases. And why was that ignored? It was ignored on the express advice of no one less than one Dewi Evans. It was on his recommendation. They consulted him and he said it wasn't necessary. So it's a bit rich of him now saying that it was, quote, not unreasonable, when he did everything in his power to prevent the appropriate and necessary, and I would say obligatory involvement of expert consultant obstetric opinion. And one has to question why he was of that view. So yeah, and then it goes on to in saying that it was there was then a bit of obviously a debate in his mind as to whose responsibility it was, and forgetting that what the researchers had clearly found out was that the Cheshire Police had seized the maternity records of all the cases. Now, they wouldn't have used that word, seized, without good reason. And then it came to light in their side of it that the defence had requested the maternity notes, but they've been refused. Now, I don't know the legality of this, but does the CPS have the right and the legal power, even if the prosecution weren't planning to use the maternity notes, to deny access to the defence? I don't know the answer to that. If that is the case, then it's gravely worrying. I thought the legal situation from my own experience and brush with the employment tribunal was that there was a legal responsibility if documents existed that lessened the prosecution's case, then they had to be declared to the defence. But is that different in a criminal case? I would have thought it'd be even more important, but one has to question that. So I think Dewi Evans has got a problem, and it goes back to I've repeatedly quoted on social media about Mark Twain's view that, you know, if in a situation like this you decide to tell the truth, then you don't have anything to remember. It's far more difficult in a situation like this if you decide not to tell the truth, because you've got to be consistent and you've got to remember a lot more, because there's no good giving different stories, which appears to me to be what is happening now.
Absolutely. So Michele, what did you make of this section, and what do you make of the disclosure issues?
There was two main points that I found quite fascinating. One is, and I think it came out by a Thirlwell, there was a note written, a handwritten note, which said the police are talking to Dr. Evans saying, do we need the maternity notes? And he very clearly writes underneath, no need for the mother's notes. So the reason why the mother's notes weren't obtained was on his direct instructions to Cheshire Police. And I don't blame Cheshire Police. They were out their depths. They don't know what they need and what they don't know. So that entirely falls onto him. The second thing was when he was talking about, well, we didn't need the maternity notes because there is a 2-paragraph synopsis of what has gone on in the neonatal notes. Now, from my understanding, those did not happen. There were not 2 paragraphs. Talking to some of the experts who've looked at these babies' medical notes, there would be 1 or 2 lines. And I think that's absolutely accurate, because I've seen baby Archie's notes. And bearing in mind that Annie went in with a pyrexia, she was query septic, she was query having an appendicitis. In Archie's notes, all it says is, mother, 2nd pregnancy, query, question mark, query sepsis, query appendicitis, and that's it. There's nothing else in Archie's notes that says anything. So I don't think anybody could glean what was going on antenatally, whether these babies had been to the fetal medicine unit, because they're not comprehensive. They're not comprehensive at all. So Dr. Evans saying, oh, there was 2 paragraphs. Paragraphs to me indicate at least 4+ lines each paragraph. That, I don't think that's true. I think that's just him trying to distract from the fact that there was a spectacular failing in getting these maternity notes.
Yeah. And of course, we know from Shu Lee's perception of the notes, having looked at the clinical records now, you know, he very clearly said to you that he and his panel had seen exactly the same. Yeah. In fact, bearing in mind they'd seen the Thirlwell documents, they'd seen more than yes. Than the prosecution experts. In his express view, there was next to no, if not negligible, obstetric detail in the neonatal notes. The other thing, of course, which I thought was even more striking in a way of what Dewi said, and again I made a note of his wording. He said most of the babies were born in an acceptable condition, and used that as a justification to not need the maternity and obstetric records. And that's interesting, because that's the first time where I've heard him say most of the babies, because my perception was that in his view, all of the babies were well and stable. So if most of them that were, which ones weren't, Dr. Evans? Can you specify which of the babies weren't?
Well, he'd have to admit that child D was in a pretty bad state pretty quickly, wouldn't he? Don't you think?
Well, yeah, but baby A was born asystolic. So, So yeah, but yeah, absolutely. But baby D wasn't in. So that was almost an admission to me that his very firmly held view that all of the babies were well and stable actually wasn't quite accurate. So I think I think there's a dawning realization on his part. I mean, just bring it on, bring it on. If there's nothing to see and nothing to hide in the maternity and obstetric records, then release them. It's the same as Steve Watts when he's saying to Cheshire Police about the police investigation. If there's nothing to hide, then declare it. Then declare that.
Yeah.
The truth of the matter is that I think there's a very, very significant amount of detail in the maternity records, which the Cheshire Police, the Crown Prosecution Service, and I suspect a significant number of individuals at the Countess of Chester realise that they cannot afford to have any kind of forensic review of the maternity notes. I think that's going to be resisted with great vigour.
I know that Mark, when he initially took the case on of Lucy, and he was recruiting his neonatal experts, they all asked for the maternity notes, and Mark went back and tried to obtain them and was told, no, they're not here. I think it will be news to him that the defence had previously requested them and that the prosecution had them, because I don't think Mark even now has those maternity notes. From my information talking to him, he says that the power comes from the CCRC and they have a lot of legal powers and they can ask for them, they can demand them. Whether the CCRC have actually done that, only Vera Bird knows that. I really hope she's watching this and that she does, if she hasn't got the notes, expedites their retrieval very quickly.
Absolutely. I echo.
A few things, Chris, about this case now that I absolutely long for, and one of those right at the top of the list is, and it will never happen, but I would dearly love to see Professor Phil Bennett under oath in a courtroom with full and unredacted access to the maternity records for the triplets OP and Q up against one Dr. Dewi Evans. Bring it on. Bring it on.
I think everyone would love to see that.
And I will be in the very front row to observe that.
Yeah.
Bring it on.
Well, it should be on pay-per-view, really, but I guess we don't do that in this country. But yeah, I mean,
when they sell the trial notes, it should be.
Yeah. Well, I've said numerous times, court proceedings should be recorded. There's no reason for them not to be, and it's taken us a while to get to all this information. It's come in drips and drabs, but this should have been available from day one. And then Lucy's campaign and Lucy's prospects of exoneration would have gone forward even quicker. I think we've done really well under the circumstances, but it's made as difficult as possible by this lack of transparency. And that's one of the things that need to change. That's one of the things I forgot to mention at Waterstones. When I was slagging the court system, I forgot to mention the complete lack of transparency, which is critical because in a situation like, I was watching this thing the other day. It was a much simpler case than Lucy's case. And it was one of these Channel 4 documentaries. I've not had time to watch them all. But even for this very short court case, they were quoted like 20, 30 grand to get the court transcript. And I just think that's a disgrace. I think it's an absolute disgrace because, how can you defend yourself? If you literally can't raise the money to get the transcript, how can you can't defend yourself?
Well, I can beat that.
They should just have AI to use it. We have all the technology. Why?
Yeah.
I can beat that with my own employment tribunal, Chris, because that wasn't recorded, it wasn't minuted, there was no transcription of proceedings. The only legally admissible record of what happened in my employment tribunal were the learned judge's handwritten notes, and you have absolutely no legal right as a claimant to access those. So as it stands at the moment, there is no record at all apart from a judgment, which is like a work of complete fiction in my case, That is the only record of what happened in my employment tribunal. That changed, I think it was a couple of weeks after my hearing ended, where they introduced, if technology allows, it was worded, digitized recording of proceedings. So even if I had the money to pay for them, you're not legally allowed access to them. So the whole thing is crazy.
Yeah.
And look at what's happened recently with the Hillsborough law. There's great rejoicing about the Hillsborough law, but just take a step back from that. So hold on. In this country, we need a law to make officials, to force officials to tell the truth in legal proceedings. What?
Yeah.
It's just staggering. I just do not know what is going on in this country.
Well, it's awful, isn't it? What else can you say? I mean, I didn't realize how bad things. I feel I don't understand why I was so naive. I assume it's social conditioning, but I really didn't realize how bad things were in the court system. My eyes are open now, so it's been an eye opener for me, and I won't close them again. That's for sure. So let's lastly. I want to comment on this first before I ask you about this, but there were statements from someone at the Countess of Chester, and then there was a statement from the Crown Prosecution Service. So we'll deal with those separately. But before we go any further, I just want to say that I thought the statement from the Crown Prosecution Service was disgusting, considering this was really egregious problems with the case that were revealed in this documentary, and given what we already know about the Crown Prosecution Service and their role in it, and I think for them to, drag out this kind of pre-prepared generic statement about, there was two juries and the defence has said various things and the CCRC is assessing all this, that's all completely irrelevant. It's all about your role in this, Crown Prosecution Service. You have to take some responsibility and ownership of what has happened here and what you've done. And for you to sit there and say Lucy Letby is found guilty and she's in prison, we know she's in prison. We know she's been found guilty. We know there was a jury. We know there was a court case. We know that she was denied the right to appeal. What the hell does that have to do with your competence and responsibility? Nothing. With that being said, what did you think of the CPS comment firstly, Michele?
Well, it's just the usual doubling down, isn't it? We're not. They're never going to hold their hands up and admit that they made a mistake. I mean, they shouldn't. The CPS that actually brought Lucy's charges, I don't think should have even been involved. It should have been the big CPS that finally looked at the Liverpool potential charges, and they said there's nothing to see here. It goes across the board. It's not just the CPS, it's the National Crime Agency, it's the police, it's the way it was investigated, it was the way things were allowed to happen. The whole thing is just such a travesty. And like you, I believed in the British justice system. I always thought, well, we might have one or two problems, but on the whole, it's good, it's honest. How wrong was I? It's not. And they're not interested in the truth. They're interested in a win or lose situation, depending on which side you're batting for. And that goes back to what's happening with these poor parents now on the indictment. Their lawyers are not interested in getting the truth for those parents. They're interested in just keeping the narrative going and shutting the whole case down. And I don't know how they sleep at night, if I'm honest. I feel so bad for those parents.
Yeah, absolutely. Do you have anything to add, Martin? And do you have any thoughts on the Countess of Chester comments? I forget the name of the lady who Susan.
Sue Pemberton.
As far as the CPS are concerned, I think the only comment I would make is it harks back a little bit to would we be in a different position if the Cheshire Police had done the appropriate thing and referred Lucy Letby's case up to the Central London major crime CPS rather than the Cheshire one. And bearing in mind that they kicked these additional charges against Letby into touch because they lacked the evidential weight to warrant placing charges, I think tells its own story really. But quite clearly they're battening down, aren't they? They're doubling down to try and do everything they possibly can to prevent this from being referred back. As far as the trusts were concerned, it's the same old story, isn't it, Chris? very carefully worded. It was the new deputy chief executive that gave the statement to Radio 4, and it's a standard that would have gone through the trust PR team, very carefully worded, and it was we apologise if any parents feel that they've had adverse treatment or deficient treatment, and let us know if you want this to be investigated. The only thing it lacked, which I presume was deliberate, in that they didn't want to actually admit that they'd done anything wrong in these cases, was that they'd learned from these cases and had appropriately amended their practices. Is about the only thing that it lacked. But she did go on to use a term that I thought was fascinating and rather amusing, in that she said that the trust now practice to or using a family integrated care approach. Well, I don't even know what that means. Mm-hmm. That's very, very, very reassuring that they use that. But I don't really understand what it means, and I suspect most parents using the service wouldn't understand or appreciate what it means either. One would hope that it involves basic standards of care, which one has to say, if you now look at the 4 sets of parents that have been interviewed, they all experienced such basic deficiencies in compassion and standards of care that that's what they should be concentrating on, rather than something that I don't even understand what it is.
And do you have anything to add to that, Michele, on the Countess of Chester and Sue Pemberton?
No, I think Martin's very eloquently summed up what she said, and more importantly, what she didn't say. I mean, all this jargon about family-centred care, the bottom line is, have you now got appropriately trained staff with the expertise, and are you correctly staffing the unit? And that's all you can say, because otherwise the same problems are going to occur.
Absolutely. So we've dealt with all of these specific aspects of the documentary. I just think in closing, I'd like to ask you both if you have any final thoughts about your feelings about the documentary, and your feelings maybe about the situation with Lucy's appeal, with the whole thing at this point in time. So if you could, ask you first, Michele.
I thought the programme was very good. It was a start. I suspect that we're going to get more and more parents with very similar stories, and tragically, probably parents who've lost babies or babies have been seriously harmed. I think the entire United Kingdom has to wake up and look at what is happening within maternity care. And I hope that the new Department of Health, Minister Yvette Cooper, is seriously going to come forward and review all of this, and not just demand another inquiry and another inquiry. We've had numerous inquiries. We know what the problems are. Can she please come forward and correct the problems, rather than ordering just another paper exercise?
And what about Lucy's case at this point in time, or the general tone of public discussion? How do you feel about that?
Well, I think it's becoming increasingly positive for Lucy. I think the general public are beginning to realise that she did not have a fair trial. It was not honest. There was huge omissions missing from what was said in court and what we now know. When the CCRC are going to kick it back, who knows? That's up to Dame Vera Bird, and I hope that she's watching and listening, because the bottom line is that poor Lucy is now 36 years of age and is incarcerated, potentially for crimes that never happened. Not only, she didn't do it, but there wasn't a murder. There might have been gross medical negligence and suboptimal care, but that's not the same thing. And I remember the days when the Home Secretary used to intervene. that would be good if the Home Secretary could intervene and look at this and put some pressure on the CCRC.
Yeah, yeah. Well,
I am quietly confident. I think we are moving in the right direction.
and same to you, Martin. How do you feel about things currently with regard to
Completely
Lucy?
agree with everything Michelle's just said. I would just add to it, extreme gratitude and compassion to the four sets of parents now that have been immensely brave and in coming forward to tell stories that quite clearly are still deeply distressing to them. And what they give us what I suspect we all knew, that this was very, very far from one individual rogue nurse in a unit. This was in keeping with the other maternity units around the country. This is a unit that was tragically very ably demonstrating systemic failures across both the maternity and neonatal services. And rather than accepting that, through the most bizarre route, managed to successfully scapegoat a nurse to take responsibility for those systemic failings. And the sooner that is recognised by the powers that be and appropriate steps are put in place to reverse this, the better for everybody's sake. It has, as you've said repeatedly, this isn't just an embarrassment for the legal system in this country. It is that, but it's also a monumental embarrassment to our country that this has happened.
Yeah, I think we'll finish on that note. Really appreciate you both joining me as always and giving up your time. I'm sure we'll meet again in the foreseeable future. So yeah, thanks so much, and fingers crossed that things continue to move forward. But yeah, cheerio for now, and we'll talk again soon.
Thank you.
Cheers, guys. Enjoy the rest of the weekend.
Yeah,
Bye.
cheers.
Bye.